have been involved in multiple myeloma since 1980, a long way. And regarding the story of minimal residual disease, that is the topic for today, I would say that this started with acute leukemia. When we treated in the 70s and in the 80s patients with acute leukemia, we were able to achieve complete responses in a good fraction of patients. However, unfortunately, many of them relapsed. And this was due to the persistence of residual cells that were not detectable with the conventional methods. In multiple myeloma, this has not been an important issue, mainly because complete response were rare until 10 or 15 years ago. But with the new agents, the situation has completely changed. Bortezomib, alidomide, lenalidomide, and now more recently the monoclonal antibodies, the second and third generation proteasome inhibitors and IMiDs have been able to demonstrate that a large fraction of myeloma patients can achieve a complete response assessed by morphology and serological methods. But again, we have the same problem. When you have 3% plasma cells after treatment, you are not sure whether or not these plasma cells are normal cells. If they are normal cells, you are really in complete response, or are malignant plasma cell, clonal plasma cell. Then you need more sensitive methods, more specific methods to assess if the residual plasma cells are clonal, means malignant, or polyclonal, normal plasma cell. And this is the focus of minimal residual disease test in the bone marrow, to assess the clonal plasma cell, the residual plasma cell for malignancy. But the concept of minimal residual disease also go outside the bone marrow, is the new imaging technique methods, particularly the CT PET, that allows you to identify residual locations of foci of plasma cell that could be associated with late relapses. All this was the reason why the International Myeloma Working Group decided in a recent paper to implement new concept for response, and are the MRD concept of responses. Let me expand a bit more, because minimal residual disease is usually, the concept of minimal residual disease is usually associated with depth of response, with quality of response, but could help not only to assess the quality of response, also to monitor the treatment efficacy in the long-term follow-up during consolidation and during maintenance. And we have a beautiful example about this with CML, chronic myeloid leukemia. Now, in the chronic myeloid leukemia patient, the treatment is adapted based on the minimal residual disease assessment by molecular techniques. In the ALL, it's also adapted by minimal residual disease method, either by flow cytometry or by molecular methods. Now, in multiple myeloma, we have started to implement these techniques to evaluate the residual cells in the bone marrow and outside the bone marrow, both by flow and molecular methods. The Spanish, the UK, the French, American groups has been able to demonstrate that patients that achieve after induction therapy in newly diagnosed patients after transplant an MRD negative status have significantly longer progression-free survival and overall survival as compared to the MRD positive patients. In fact, we have recently shown that the patients that achieve CR, conventional complete response, in this cohort of conventional CR patients, you have two cohorts. The ones that are MRD negative and the ones that remain MRD positive in spite of in serological complete response. The MRD positive one are similar to the VGPR or the partial responders. The ones that really benefit from the treatment, from this good response, are the MRD negative ones. Then one of the aims currently in myeloma treatment is to put the patient into an MRD negative status. Due to the pattern of bone marrow infiltration in myeloma, different from leukemia, that is a patchy bone marrow infiltration, while in leukemia it's more diffuse, you may have a situation in which you don't detect cells. In other words, you are MRD negative, but the sample was not representative enough of the whole bone marrow due to this patchy marrow of infiltration. By contrast, if you detect residual cells, by sure the tumor is there. Then I like to say to my patients, look, good news, you are MRD negative. This is good news because to be MRD positive is bad. I know the definition that MRD positive is bad. MRD negative is good, but it's not totally good, since some patients may relapse in spite of being MRD negative because the sample was not representative enough. But the news are very good because you are not MRD positive. Then this concept, I think, is very relevant to be understood. Regarding your question about whether or not MRD negativity could mean cure or could become a surrogate marker for cure, I think the answer is going to be yes. I have just mentioned about the pitfall that you may have with a non-representative bone marrow sample when you do the analysis that is reported as MRD negative, but the bone marrow was not the ideal one for this exam. Therefore, you may have an error in that case. But when we are considering MRD negativity as a surrogate marker for survival, we are not going to rely in just one sample. What we want is to maintain an MRD negative status, at least for a period of time. If you repeat this bone marrow 2 or 3 times just to confirm the MRD negative result, the 2 or 3 subsequent samples by sure are not going to have this problem in case you have that problem. And the demonstration in a sequential fashion that the patient maintain an MRD negative status is becoming more and more robust indicator of disease-free, long survival, and probably in the near future, and similar to what is being implemented in other malignancies, we are going to have MRD as a surrogate marker for survival.
Professor San Miguel, thank you so much.